Okay, Dave Burns.
Good afternoon and welcome everyone to this patient-focused webinar. I'm Dave Burns from Insight Tech, and I'm pleased to be a part of today's virtual educational event. We want to thank all of you for your attendance and your participation. The goal of today's presentation is for educational purposes. We are very fortunate to be hearing from Dr. Greg Bonnen from Houston Physicians Hospital, as he will discuss focused ultrasound as a treatment option for patients diagnosed with essential tremor or Parkinson's disease. As questions arise during the presentation, please utilize the Q&A button located on the bottom of your screen. We encourage any and all that you have in mind. No question is a silly one. And at the end, we will have time after the presentation to answer the questions that are asked. Let me begin by introducing you today to our presenter, Dr. Bonnen. Dr. Bonnen is a board certified in neurological surgery by the American Board of Neurological Surgery and a fellow of the American Association of Neurological Surgeons. Dr. Bonnen serves as the chairman of the board of Houston Physicians Hospital here in South Houston. He grew up in Angleton, Texas, and graduated cum laude from the infamous Texas A&M University with a Bachelor of Science degree in biochemistry. Gig 'em. He earned his medical degree at the University of Texas Medical Branch Hospital in Galveston, where he also completed his internship and residency. There he served for 2 years as an assistant professor of neurosurgery. Since June of 2021, Dr. Bonnen has performed close to 400 focused ultrasound treatments. Welcome, Dr. Bonnen, and thank you ever so much for presenting today. The floor is all yours.
Thanks, Dave. It's good to be with you today. And what we're going to do is go through a little bit of background that will provide some useful information as it pertains to focused ultrasound and how we're able to treat movement disorders today. And then after we get through that presentation, we'll have time to answer your questions. So with that, we'll go ahead and get started. And this just gives you a little bit of an overview of what we're going to cover. We'll talk about essential tremor and how common it is, and we'll talk about focused ultrasound and exactly what that is, who's a candidate to be treated with this type of treatment, what the outcomes look like, what the experience is for somebody that's actually going through that treatment. Is it covered by insurance? Which it is, but that's a very important question. And then we get asked a lot about, can we treat both sides? Because a lot of people have tremor on both their right and the left side of their body. And we'll discuss that and then go on and answer your questions. So here's some basic information about essential tremor. It's extremely common. There is no known cause, so we don't know why people would necessarily end up with essential tremor. About half of the time it is hereditary, and it's really common that patients will share with us that they have a parent or a sibling who has the same thing, and we've actually treated family members, but not every case is familial. And the critical part of this is that while in the beginning it may be a nuisance or something that is a little bit irritating but not debilitating, as the years go by, it can reach a point that it makes it really difficult to do just simple basic daily activities that we all take for granted, like being able to write your name or drink from a cup, or brush your teeth, or do or undo buttons. And so, how common is this, and what is the impact? Well, I mean, as you can see there, it's extremely common. There are millions of Americans that experience this. And frankly, many, if not a majority of them, will choose to live with the tremor, even though it interferes with simple basic daily activities, and they won't seek treatment. Or, maybe they'll have treatment with medications, but the medications just really don't prove to be adequate to control their symptoms and or they'll have side effects related to the medications. And that's what brings us to considering something like focused ultrasound, a situation where the tremors truly become debilitating and the medications are not really effective. So this gives you a little more background information about the number of people in the country that will experience this. And you'll also note on here that while the vast majority of patients with tremor have essential tremor, there is also a large population of patients with Parkinson's. And we have had some success in treating Parkinson's with this type of modality. That's something else we may get into a little bit later. And, it's a little bit nuanced because there are different target locations in the brain that can be useful. And what we're going to talk about today really pertains predominantly to the target that's most helpful at managing tremor. And then when it does come to Parkinson's, we do get into some issues of whether Medicare has decided to provide coverage for that, whereas that's not an issue with the essential tremor population. And this just gives you a little bit of an overview of what I've already been discussing, which is that medications tend to be the first line treatment. And the most common medications are things like primidone or beta blockers such as propranolol or Inderol. And, those for most patients provide maybe a little bit of relief, but usually not dramatic relief. And then quite often they cause unwanted side effects. There are a whole menu of wearable devices that can be somewhat useful and can help people to adapt to how they can cope or manage with the tremor. And then there's the procedural types of interventions, and that could be anything from injections to doing a thermal ablation in the brain. And there's a whole history of this. So interestingly, while the technology is extremely current and is a huge step forward, the concept of heating up this specific target in the brain to alleviate tremor goes back to the 1950s. And we call that a thalamotomy. And that can be done with a radiofrequency probe, which is how I first started doing it in the 1990s. It can be done with focused radiation, but now we're able to do that with ultrasound. And then there's also high frequency stimulation, which is a type of pacemaker, if you will, for the brain. And we've got really good experience with that over the last 20 years or so in the United States. And so we'll talk a little more about the procedural interventions. So another common question that we get is how long have people been using focused ultrasound and what is the experience? And what this shows you is basically just a timeline. And you can see that it's been under development for, almost 20 years. FDA approval for treating one side was back in 2016. But as you can imagine, until it was covered by Medicare and other forms of insurance, it wasn't very common. And so in 2018, that's when there was nationwide Medicare coverage, along with in 2018, FDA approval for treatment of tremor dominant Parkinson's. But really, the key milestones would be in 2016 FDA approval, in 2018 Medicare deciding to cover it. So what that means is the last really 5 to 6 years have been when the bulk or the vast majority of cases have been done. Since that time, there's been FDA approval now to treat the second side in patients. We have to wait 9 months before we can do the second side, but it is FDA approved and it is covered by insurers in our experience. We also have FDA approval to target a different location in the brain to treat Parkinson's. And again, that is not an entirely new strategy. This is a new technology to do something that has actually been done for decades. But the challenge we have there is still getting Medicare coverage and insurers to cover that. So, what is it that we're actually doing with focused ultrasound? And if you look at this, you'll see on the right side someone trying to trace between the lines and do spirals. and then below that immediately after treatment. And what we mean is literally during the course of treatment, over the course of an hour, this is the type of change that we commonly see. And the way that it works is these ultrasound waves are emitted from a combination of channels, typically in a given case, about 950 to 1,000 different channels. So they're all coming from a little bit different angle, and where they all come together in one very narrow, small, specific location in the brain, it deposits heat. And we can control how much heat and for how long, which creates what we call a thermal ablation in that target area. And the target area is an area called the thalamus, and it's a relay station that lies kind of in the center part of the brain. And when we treat that area, people will see a very significant, often dramatic relief of their tremor. And this goes way back again to the 1950s when it was first recognized and done to try to help people, but not obviously with this technology, which doesn't require an incision. It doesn't require anything mechanically to be placed into the brain. There are no implants. And it also doesn't require a general anesthetic, which is very important, especially for dealing with patients maybe who are older and have other complicating medical factors and would be a high risk for anesthesia. So who would qualify, for treatment? And as you kind of gathered from the timeline, it's patients that have either essential tremor or a tremor dominant form of Parkinson's disease. And the tremor has progressed to the point that the medications that they've tried or are taking are just not adequately controlling their symptoms. There is an age threshold, if you will, and that is 22 years or older for essential tremor and 30 years or older for tremor dominant Parkinson's. And as you would imagine, the vast majority of our patients are significantly older than that because it's more often that people get into their 50s, 60s, 70s, 80s when this actually manifests and becomes severe enough that someone would want to consider this type of treatment. We don't provide sedation during the treatment, but in our experience of almost 400 cases now, that hasn't been a problem. It's actually, in many respects, easier than MRI in the sense that there are patients that we have that are claustrophobic and struggle to be in an MRI unit, but they seem to be able to tolerate having the focused ultrasound procedure done a lot better than that. Now, part of that is even though it's done in the MRI suite and we use MRI, the patient's not actually in the actual opening or bore of the magnet for more than about 10 minutes at a time. And then they slide out so they have more space to move. Obviously, it's important that people can communicate during the procedure because what we'll do is we'll go in and we'll actually examine the patient and have them draw or hold a bottle and monitor their progress. Um, Being able to fit into the scanner obviously is important, but again, not something that is a practical matter we've really found to be an issue for anyone. And we do have a ball, if you will, that is a device that if the patient squeezes it, it can stop everything and alert the team to come in and check on the patient if they're having any kind of problems. You must be able to be able to have an MRI. And so a common question that we'll encounter is, will I have a pacemaker or some other kind of implant? And we always track those down, and not just based on the manufacturer or the device, but literally by serial number to see if the device is MRI compatible. Most pacemakers, in our experience today, actually are MRI compatible. They may have an MRI mode or a setting that we have to put the device in order to do the procedure, but that typically is not a problem. And then they also, the patient must have a certain efficiency, if you will, for the skull. And what that means is that we're trying to transmit these ultrasound waves through the skull. And not surprisingly, people may have a different anatomy. And the skull has different layers in certain parts of it, and an inner layer, an outer layer, and then a middle layer that tends to be more spongy. So kind of like a piece of plywood. And the density ratio of these layers, along with some other factors, including shape and thickness, will factor into how easy or how hard it is for the sound waves to get through the skull down to the target. And we've got a minimum threshold of efficiency, if you will, using the skull density ratio as just one important measure of that. And if the patient is essentially 0.40 or above, then they would meet the FDA requirement to be treated. And that happens about 95% of the time. We do occasionally run into patients that their skull is so inefficient that we're not able to use this type of technology to treat them. And the reason is not that it would be dangerous, but rather that we just know we're not going to be able to get enough of the ultrasound delivered to the target, and we won't reach a hot enough temperature to give them lasting relief from the tremor. So this gives you a little bit of an idea of the total volume of patients that have been treated, and in the slides a little bit older than than current times, but you can see that it's thousands of patients that all the patients, all the surgeons or doctors that are doing this combined have a pretty vast experience. And then what the numbers here on the right are showing you is the increase in the experience as this becomes more commonplace and people are enjoying more success from the treatment. So what's it like? If you're the patient, what would you expect to experience if you're going to have this done? So it's an outpatient procedure. You would come into the hospital on the day of the treatment, probably about an hour ahead of time. You'd check in just like a regular patient. You'd go to a preoperative area, and we do shave the patient's hair. And the reason for that is because it can otherwise interfere with the transmission of the ultrasound. And we also use cold deionized water, which serves a couple of purposes. One is transmission, and the other is also cooling of the scalp during the procedure. So we do have to shave the patient's hair in order to do this. Now, it's not a situation where there's any toxicity associated with this. And that's a distinction from, say, being treated with radiation or chemotherapy, where the hair is actually experiencing damage or injury from the result of the radiation or the chemotherapy. This is just a really short haircut, literally, and so the patient's hair will grow back. In the preoperative area, we go ahead and place a frame, and the purpose of the frame is to keep the patient perfectly still. The area that we're going to target is about the size of a pea. It's just a few millimeters. And so this way we don't have to worry about movement, the patient coughing or sneezing. And the head is the only part that is stationary. So you can move your arms and legs, you can adjust your shoulders or your hips. That is not actually a problem. And then the whole thing is done in the MRI suite with the patient lying on the MRI table. And the first thing that we'll do is we'll spend about 6 to 10 minutes doing an MRI. And then off of those images, we'll go ahead and plan the procedure, which takes a few minutes. We'll, with the computer software, fuse a preoperative CT scan with the MRI. And then after that, we'll actually begin the sound treatments. And the sound treatments last anywhere from about 11 seconds to maybe 30 seconds, depending on the efficiency of the skull. But the point is that it's almost always in that, say, 15 to 20-second range, typically no longer than 30 seconds. These are not long treatments. We'll do 2 or 3 of them, and then we'll go check on the patient, and we'll have the patient do the same simple tasks that you've already seen the drawings, where they'll draw their spirals, do straight lines, write their name, hold a closed bottle of water, and we'll reassess their tremor. And as we make progress and we're satisfied with the targeting, then we'll do typically 2 additional sonications with a little bit higher intensity, if you will, so that we can make the improvement more definitive and long lasting. After that, the patient's removed from the MRI table. It takes about an hour to do the whole treatment. sometimes less, sometimes a little bit longer, but not much. And then after that, we take the frame off, and the patient will go to a room, visit with their family for about 30 minutes, get something to eat and drink. We'll have them do one final drawing with them sitting up, and check their blood pressure and heart rate. And then after that, the patient's discharged, and so the whole thing is done as an outpatient. So it's pretty rewarding, if you will, in that you can see an immediate improvement. You don't have to wait hours or days or weeks or months to see an improvement in the tremor. And the results have been, really, really lasting in the experience of thousands of patients now. The improvement in quality of life is really the whole point of doing this, is to allow people to do things that they've not been able to do because of the tremor and get back to being more independent. There's no anesthesia, there's no incision, or no reason to keep the patient in the hospital. Literally, I've never seen anybody acquire an infection from this treatment. And then, of course, there's no implant. No radiation is involved. The MRI unit is a big magnet, and of course, no anesthesia. And this is just a video of a patient before and after the treatment. So let's briefly talk about insurance coverage. If you're going to have this, we're always going to want to verify before actually doing the procedure that, in fact, your insurance will cover it. Medicare does cover it, and Medicare tends to be the trendsetter, not just for this, but for many other things. And so the experience is that the major carriers now do cover this procedure, but we always verify that. And to the extent that you may have a cost share, meaning a copay or a deductible, we identify what that's going to be ahead of time. So there's no surprise as to what it may cost. The cost of this procedure is actually uh, significantly less than a lot of other surgeries that we do. Another comparison or contrast would be DBS, which I still do on a consistent basis. And the reason for that is that the implants are pretty expensive, and there's no implant associated with this treatment. And then there's also no admission to the hospital. So those are two major cost savers with respect to this particular type of treatment. So what about doing the second side? In the very beginning, we could only do one side, but a clinical trial, was done that demonstrated that we can not only safely but also effectively treat the other side. But we wait a minimum of 9 months before doing the second treatment. And the reason for that is medical, and that is that if we were to do the second side too quickly after doing the first, there could be some unwanted or unintended consequences at the initial treatment site. So basically, we let everything settle down internally before proceeding with treatment of the other side. And we've done, I think, maybe roughly 50 patients now that have come back and had the second side done. And this is an overview of the clinical trial that was done. And, we've actually, outside of the trial, done at least, this number of patients. So it is now FDA approved and covered to do the second side. So, question and answer and next steps. I think there is one other thing that I would mention before we get to questions, because this is something that's really important and that I would surely think would be a question. And that is, what kind of side effects or complications could you have from having this done? And the answer to that is pretty specific to what's in the area that we're treating. So the way this technology works is it's depositing heat incredibly precisely to a very specific area. But having said that, there's a little bit of warming around the area of the target. So as good as it is, you don't go from zero heat to normal temperature in a, in a cell or in a tiny, tiny area. So you may have a little bit of warming around that, and that can affect the tissue in the neighborhood, if you will. So the most common side effect that people may complain of is about a quarter of the time, patients may say they feel a little bit less steady on their feet. And if they really pay attention, they'll know that the side that we treated, it seems like they list to that side that was treated. Now, at least 3/4 of the time that didn't happen. But when it does, it is usually not anything that is debilitating, but more something that you should be aware of and be careful, because we don't want you to not recognize it and then have a fall and hurt something else. And then as the days and the weeks go by, any swelling that you may have around the target subsides, and then that side effect subsides. Probably the second most common thing is it's not unusual for people to have some numbness or tingling on the treated side. You wouldn't get that on the other side, but on the side that we treat. And it's more frequently around the lips or the tongue, although it is possible to have it also in the fingers or fingertips, but that's pretty rare. But occasionally we may see it in around the lips or the tongue. Much less common than even the difficulty with balance or feeling a little bit off when walking. And while it's certainly possible that that could be a permanent or lasting problem, again, it's typically a result of swelling around the treatment area. And as the swelling goes down, then that gets better. So those are just the two most common things that people may encounter. And with that, I think we'll just go ahead and move on to your questions.
Awesome. Thank you very much, Dr. Bonnen. That was very informative. And I do want to encourage folks. We've got a handful of questions to begin, but please add to as you feel appropriate on your end as well. Notate the information on your screen right now. The teams at both Houston Physicians Hospital as well as Dr. Bonnen's office are outstanding. So any additional questions you may have, please follow up and follow through. So with that, let's go to our questions. Oh, we've got an Aggie in the house. This is beautiful. Question, is the VIM of the thalamus close to any glands that control other chemical transmissions that could be affected by focused ultrasound?
Yeah, so the target area, this VIM segment of the thalamus, isn't adjacent to any endocrine or hormonal glands. So that wouldn't be an issue. It is a relay station, and so messages that are coming from one part of the brain are then being relayed to another part of the brain that controls movement. And that is why targeting this specific relay station can help to alleviate the tremor. But there are no glands that are in the neighborhood of this particular target.
Wonderful. Follow-up from the same individual. What is the strength of all the ultrasound radiation at the target, and what functions do the surrounding cells have? Are they affected?
Yeah, that's a great question. So, in terms of strength, the way that we measure this as we're actually doing the procedure is really, I guess I would say three things. We look at the amount of energy or power. We look at the amount of power that's being used, and then we'll also look at the duration or the time over which it's being administered. And really, the third part of where we're trying to end up is we can actually assess or measure with thermometry the temperature that we achieve at that target. And so how much power that you would use, how many joules of energy that you would deliver over what length of time is going to vary depending on the efficiency of the skull. So you might use a higher power level for a longer length of time, which means more energy being delivered. But if a lot of it is being filtered or blocked out by the skull, what's actually delivered at the target, may be the same or less than what a different patient would have delivered at the target with a lower power level and a lower amount of energy delivery. So we do monitor those things, but the bottom line is the temperature that we're able to achieve. And the temperature that we're really shooting for to achieve permanence, to make the benefit to the patient lasting, is typically on the order of 56 to 58, 59 degrees Celsius. And, it's not even quite as simple as just temperature, because the time at temperature also matters. So you could have, say, a 56 degree or 57 degree temperature, and if it lasts for 10 seconds or 5 seconds, that's different than achieving, or not the same as achieving, say, 58 degrees for 1 second. So it does get a little bit complicated, but we have the ability with the software to measure the size of what we estimate to be the permanent ablation or lesion in that target area. So it's a little bit maybe technical, but that's a basic way of thinking about it. And in terms of what's in the neighborhood, there are really two things that we're trying to basically get close to, but not get into, if that makes sense. So the one would be just a little bit lateral or toward the outside would be the internal capsule. And this is where the key messages that are going back and forth, or back from the brain to the other side of the body to control motor function, are being transmitted. So in order to get a really good result with the tremor, we want to be in that part of the thalamus that's in the lateral part of it, but not so lateral that we leave the thalamus and get into the internal capsule, because that could create weakness or maybe a little bit of a difficulty with fine motor skills or rapid movements. And so that's where the targeting is really important. And then the numbness and tingling is the other possible side effect that I mentioned earlier. If we start to notice that at lower temperatures, then we may move the target forward a little bit to get away from that area, and that typically will solve that problem. The anatomy is very well worked out, and we are very precise in the targeting. However, patients, as you would expect, are different in terms of their size. And so even though the basic anatomy is the same, the measurements, particularly in terms of from right to left, may vary from one patient to another based on a combination of the size of the patient and the size of their brain, and then also the anatomy with respect to fluid space that is kind of like a lake of spinal fluid. We call it the third ventricle. And if you have a very thin one, then the distance from the center of the brain out to the side is going to be less than if you have a very wide lake of spinal fluid in the middle of the brain, in which that measurement from the middle of the brain out to the target area may be greater. So we have we have ways to calculate that, and then that's part of doing the MRI during the procedure, is to also visualize this anatomy as we decide the proper target.
Right. Kind of while we're on this subject, I'm going to leapfrog one question and then come back to this one, since you're right there with it. What is the purpose of the VIM of the thalamus?
Again, it's a relay station that is receiving communications from one part of the brain and then sending them to the motor cortex, which sends messages back down to the arm and the leg and the face for control of movement. And even though we don't know why people, for example, develop essential tremor, or precisely why they might develop tremor dominant Parkinson's, we believe, certainly in the case of essential tremor, that there is a group of cells not in this part of the brain in the thalamus, but the part that's sending messages to the thalamus are hyperactive. So they're sending too much stimulation. They're sending signals that are more abundant than what they should, and then that hyperactivity, if you will, is getting relayed up to the motor cortex. So by ablating the small portion of the relay station, it reduces that overstimulation of the motor cortex.
Very good. Thank you. Does finger dexterity return?
So that's a really good question. Does finger dexterity return? And I would like to unpack that a little bit. So if a patient has a really profound tremor and it's the tremor that interferes in the dexterity, then there's a dramatic improvement in terms of their dexterity and ability to use that hand. However, uh, take the case of someone with Parkinson's, for example. Tremor is certainly a common feature of Parkinson's, but it is not the only feature. And many patients with Parkinson's will have what we call bradykinesia, which means they have a hard time initiating movements and they have a hard time with fine motor skills. And that is separate and apart from the tremor. And so alleviating the tremor isn't going to solve that underlying symptom of bradykinesia. So in a case like that, I wouldn't expect the fine motor skills to get better. The tremor may be better, but they could still be bradykinetic. And then finally, the third thing would be that I do have patients that do things that require a lot of fine motor skill. I mean, we've had people that enjoy playing the piano, playing the violin, things that require a lot of dexterity. And sometimes what they'll describe to us is that when they had the tremor, the slower motions that required a lot of precise, slow movement were very difficult, if not impossible, because the tremor would get in the way. But they could do the faster motions a little easier. And then it can be the reverse of that after treatment, where now their dexterity with respect to slow motions is much more precise and better controlled, but the more rapid motions are the ones that tend to be more difficult for them. And that's not necessarily across the board, but that is another side effect that some people might experience. Now, somebody that just wants to be able to write their name or brush their teeth is not going to be as aware of that as somebody that's trying to play the piano. But those are all different scenarios in which you could see an improvement in the fine motor skill if the problem before was strictly related to tremor, but you're not going to see an improvement if it was related to bradykinesia as a symptom of Parkinson's. And you could have the difficulty with rapid fine motor skills, even if it's essential tremor after the thalamotomy, although not everybody will, but that is a possibility.
Right. And it's a great lead right into this next question. And I think you kind of addressed it with what you just said, Dr. Bonnen. Here goes. If I have essential tremors with medication prescribed and also Parkinson's not yet on medication, would this be a procedure to consider? Number one, the tremors are not life altering, but they are prohibiting me from doing normal things like eating soup with a spoon.
Yeah, so that's a great question, and again, one that you probably should be unpacked just a little bit. And that is if a patient truly has tremor dominant Parkinson's, then if they're not yet on any medicine for Parkinson's per se, there probably is an opportunity to improve on the symptoms with some medication to treat the actual Parkinson's. So that would be one avenue to consider, pursuing. Now, sometimes people have a hard time with side effects from the Parkinson's medication, which doesn't mean they don't have Parkinson's. It doesn't mean that they don't respond to it. It just means that the side effects of the medicine make it worse than not taking the medicine. But for a lot of patients, a little Parkinson's medicine can actually really help to better manage their symptoms. But if, despite medical management, you can't use a spoon, or drink from an open glass or a cup, that is a quality of life issue. This type of procedure definitely can help with that. But that is a little bit of an area where it's not entirely a medical, question. It's a quality of life question for the patient. And so if the patient says, it's annoying, but I can live with it, I really feel fine, then you don't need to worry about having a treatment. But if on the other hand, it's reached the point where you say, this is not just annoying, it's truly interfering with day-to-day life, then in that case, perhaps it is worthwhile to move forward with treatment. But
Right.
if you're not yet on any medicine for Parkinson's and you actually do have Parkinson's, I would certainly consider that.
Great. Thank you. How soon can you return to normal activities after the procedure?
Very, very good question. And, we really don't significantly restrict people after the procedure. And, the fact is, other than just wanting to use some very practical, I hate to say this, but common sense. We don't want you to, for example, be a little unsteady on your feet, not realize it, and then fall and have an orthopedic injury. But otherwise, as you're able to safely resume normal activities, that is perfectly fine. And people ask, for example, about flying on an airplane. Let's say they're coming from out of town. Is it safe to fly after this treatment? Yeah, it's no problem. Okay. Driving, probably the single biggest thing, because in our society, that's a big issue for autonomy and being able to take care of yourself. And some people will say, oh, you shouldn't drive for 2 weeks. Well, really, there's not a perfectly defined time. And what it really boils down to, from my standpoint, is quite simply being a safe driver. There's not anything about riding in a car or operating a vehicle that's going to have a direct impact on the treatment that we're doing in the brain. The issue is if you feel a little under the weather, if you don't feel great, if your reaction time isn't good, then we just don't want you to have an accident driving the car. And that's going to vary from one person to another. There are people that in much less than 2 weeks, they feel perfectly fine. But then there can be other patients that need a little bit longer before they feel really up to driving. And then there's different kinds of driving. There's driving that's a very short distance locally at low speeds. It's not very stressful. And then there's driving a long way on the freeway, which is a lot more stressful. And so those are just very practical ways of thinking about when could I return to driving or when could I return to normal activity. But it's not like a fracture where we're going to immobilize that person so that that fracture can heal for the next 12 weeks and only then can they resume activity. There's no restriction like that. It's really more of a practical restriction in terms of not wanting the patient to have an accident.
Great. Thank you. I know you covered this earlier, but I think worthy to go through once again is just to rehash on the effect on balance and for how long post-treatment.
Yeah, and that is the most common thing that we see. Having said that, most patients are still independent. In other words, when I say independent, I mean they're not using a cane or a walker. They're just aware of the fact that they're a little bit off from what they normally would be. And again, that's about maybe 1 out of 4. This will subside as swelling around the target zone subsides, and that can take days to weeks to even a few months, just gradually going away. Now, another observation, if you will, is that patients that are normal, steady on their feet, don't require any assistance to ambulate pre-treatment, typically don't have much problem after treatment. However, if somebody comes in, let's say they're older, they've got a lot of orthopedic problems, they've got other medical problems, and they're using a walker for assistance before we've ever treated them, they really don't have a lot of reserve. So if you take someone who's very unsteady pre-treatment and you make them just a little bit more unsteady, it's easier for them to be aware of that. That would be the downside. It's still typically going to get better, but the silver lining would be they're already using a device to help them. And so the ones that, if and this is unusual, but the people that would make me more nervous would be people that don't want to use a cane or a walker and are really unsteady and are a fall risk. So that's actually kind of the more concerning scenario, which is rare. That's unusual. But I would say in terms of the length of time, it's usually weeks for that to gradually dissipate.
Great. Thank you. I have Parkinson's. How should I address this?
So that is the question. I have Parkinson's. How should I address it? It really depends on your specific situation. Meaning, with Parkinson's, there's actually a whole spectrum of symptoms. And there are patients, they're what we call very hyperkinetic, meaning they're tremor dominant. They've got a lot of tremor. They typically respond well to the Parkinson's medication, but they may get side effects such as what we call dyskinesias, which is an uncontrolled movement when the medicine's at its peak. And if you've ever seen anybody with it, it's very distinctive. And at the other end of the spectrum, there are patients with Parkinson's that have little to no tremor, and they have more of this bradykinesia that I referred to earlier, which means they have a paucity of movement. They have a hard time initiating movements. It's more difficult for them to get up out of a chair. It's more difficult for them to put a key into a doorknob and unlock the door. So fine motor skills become even more challenging for them. And so how those patients are managed is going to vary depending on their spectrum of symptoms. Other things that are going to factor into that are their age, complicating medical factors. How long have you had Parkinson's? And, if you're in the first few years, you're responding well to medication, we're probably not going to consider any kind of surgical treatment, whether it's focused ultrasound or DBS. But as patients get further into their Parkinson's, a lot of the time what happens is the medications start to lose their effectiveness. They'll start taking higher doses and additional medications. Maybe they begin to have side effects from the higher doses of the medicines, and then their quality of life starts to fall off. And that's the beginning of a window of time where a surgical intervention can really be helpful for them. And DBS has been done now for about 20 years for this. The focused ultrasound is really good for the tremor part of it, but not for the other symptoms associated with Parkinson's. Something I'm excited about is that the globus pallidus has been FDA approved for treatment with focused ultrasound to do what we call a pallidotomy. However, at this time, it's approved for one side and Medicare is not covering it, which really obviously restricts our ability to use that as a treatment modality. So I think in the future, we may have some additional options for patients with Parkinson's when it comes to focused ultrasound. But right now, it's pretty much limited to tremor dominant Parkinson's. But what would be best for a specific patient really depends on their specific situation.
Great. Thank you. We've got a savvy audience. This is awesome. Very common question. How long does this treatment last? And would I ever have to have it done again in a few years?
Yeah, that's a great question. And so with respect to how long it lasts or retreatment, which are really kind of two things, I would say that while with the vast majority of patients that have been treated, it's been within, say, the last 5 years or so, even though it's been much longer that it's been in development. But if you want to talk about the large volume of people, we don't really have thousands of patients that are, say, 25 years out from this treatment. However, thalamotomy is not new. I personally first started doing it in 1995, but we did it, what you could call the old-fashioned way, meaning we made a small incision, drilled a hole, put a radio frequency probe into the skull, and then heated the tip of the probe up. So we were still doing a thermal ablation, but doing it in an invasive way with an older type of technology. Nonetheless, I do think that that experience has value. It has merit. I think you can draw from that experience to look at, well, how durable might the results be? And the answer is most patients are going to have excellent relief of their tremor for some number of years. But rather than looking at an individual person, I would say if you look at people collectively, what you'll see is that at 5 years, 10 years, 15 years, 20 years, 25 years later, as the time goes by, the percent of patients that are experiencing some recurrence, and it doesn't mean it's as severe as it was before, but the percent of patients starting to notice some of the tremor coming back is going to increase the longer you go from the time of the initial treatment. And for some of them, it may just be something they're aware of. It may be a nuisance, but it's not debilitating. But how severe it is, it's going to be the same thing. The further you go in terms of years from the treatment, the larger the percentage of patients you'll have that say it's become more of an issue for them. So What I would tell you in terms of retreatment is that we know for certain that that can be done. So if you've had it done once, we can definitely do it in the years to come. This is purely anecdotal, but I do have a patient that in 1994 had a thalamotomy done and had a really great result. They were in their mid 40s when this was done. In fact, this person worked as a general surgeon, believe it or not, and was able to continue practicing. But fast forward 28 years to 2022, and the tremor had returned and had reached the point that it really was debilitating. This person was retired at this point, but we did a focused ultrasound thalamotomy in the same target where they had done the thalamotomy in 1994 using a radiofrequency probe, and they had a really great outcome from that. So we know that we can retreat that area. So you don't burn any bridges, if you will, with doing this. Now, in comparing and contrasting it to DBS, DBS is more invasive. It involves an implant. A lot of people are anxious about having DBS done. However, we can treat both sides at once. And because it's programmable and adjustable, it's a pacemaker type technology. 5, 10 years later, the patient could just be sitting in the office and you can change the settings on the implant to account for progression of the disease, if you will. So it adds that layer of flexibility, whereas with focused ultrasound, we would go back and we would have to repeat the procedure if, say, 10 years later, the tremor had returned and was severe enough that the patient wanted to have treatment again. Another less common scenario is we do have patients that have had ablations that have gone on to have DBS. My personal experience with that, however, is not so much with focused ultrasound, but rather from the mid 90s into the early 2000s, doing ablations like thalamotomy and pallidotomy with the radiofrequency probe. Then DBS became FDA approved in the early 2000s, and some of those patients who had had ablations in the 90s came back, and we were able to do DBS stimulators on them, and that worked just fine. So you're not burning a bridge with a focused ultrasound thalamotomy. If you wanted to opt for DBS in the years to come, it would still be a possibility. We don't typically see patients going from DBS to focused ultrasound. However, believe it or not, I do have a patient that did have that experience, and that was because they had DBS done. It was done in another part of our state, and unfortunately they became infected, had to have the implants removed, and so obviously they weren't receiving any benefit once the implants were removed, and they didn't want to go back and do DBS again. We did a focused ultrasound procedure on them, and we were able to do that successfully. So that's unusual, and you can't do focused ultrasound with the DBS implants in place. They would have to be removed if that were to be a consideration. So that's rare, but those are kind of some of the different variations, if you will, of scenarios that might play out.
Great, thank you. And I want to be sensitive to your time, Dr. Bonnen. We still have a handful of questions, some very good ones. So if you can continue on, is that good for
Sure.
you?
Yes.
Wonderful. Post-treatment, what are the effects on eating and drinking?
Yeah, so the effects on eating and drinking are going to be directly related to the effect on the tremor. So there's typically no interference with swallowing. So in that regard, it's really not an issue. It's a question of being able to get a bottle or a cup or a glass or a fork or a spoon to your mouth, which is a real problem if you've got debilitating tremor. And in that regard, it tends to get much better. But in terms of the actual swallowing mechanism, it really doesn't significantly have an impact.
Great, thank you. I tell you what, we have all these Aggies piling on. This is beautiful. What is the success rate of the second side treatment?
Yeah, so second side treatment has been very successful. I typically don't think of it as being significantly different in terms of the effect on the tremor from the first side. And I think that's been proven out with the clinical results. Now, having said that, the side effect or the risk profile is very favorable. But I will say that I think when we do the second side, that sometimes there may be a little bit more likelihood to have some side effects that maybe weren't experienced on the first side. I can't fully explain that, but I do think that that is a possibility. So we've had some patients that had zero side effects on the first side. Maybe they had no gait instability, no difficulty with numbness or tingling, and we did the other side, but they did have some of those side effects. But really, in terms of effectiveness, we've not seen a big difference between the first side and the second side.
Great. Thank you. Essential tremors tend to increase when I am under stress or rushing, like trying to catch a flight. Does the procedure totally eradicate the tremors, or can one expect to still have milder tremors?
Yeah, I think that's a very good question. And, I would say that, first of all, for stress, fatigue, caffeine, other types of stimulants, those all classically make tremor worse. So that's a very common experience. If people haven't eaten, for example, another thing that will commonly make their tremor worse. In terms of what to expect afterwards, in the beginning, I would tell people, hey, if we can get 60 to 90% improvement, that's really success. That's good. Um, but our experience has been that it's much closer to 90%. And we have people that don't have any tremor afterwards. But I wouldn't ever say to every patient, oh, just expect all of your tremor to be gone. I don't think that that's, realistic. And so to the point of the question, yeah, I mean, the tremor may be dramatically better, but if you're fatigued and stressed and in a difficult situation, you certainly could experience some mild tremor even after the treatment. I mean, that's just a realistic, practical, possible outcome.
Great. Thank you. Another great one. If you've had a skull fracture or concussion, would that keep you from this procedure?
Yeah, the simple answer would be no. Now, obviously, that's assuming it's in the past. I mean, we would not treat somebody within a short time frame of a fracture or a concussion. We would allow for time for that to heal and for the patient to recover. But assuming that this is something that happened in previous years, then that's not going to be a factor in the treatment.
Okay. Good. Thank you. I am currently taking propranolol and primidone for 12 years. 2 years ago, I undertook 3 Botox injections over several months in both forearms and neck. I ceased the injections as they affected my ability to play bass guitar. I had no strength or grip in either hand. Playing bass is my passion. Will focused ultrasound affect me the same way?
Great question. So I would not expect you to have weakness in the way that you experienced after the Botox injections, which I'm would expect would have been transient weakness. Okay. The other thing that can sometimes happen with Botox is that patients become refractory to it. So maybe the first or the second time they have it, they have a better experience with better success at managing or reducing the tremor than they do with subsequent injections. But to get really to the heart of the question, we don't expect patients to have weakness. Certainly, it's a risk, but that is extremely rare. So you shouldn't have weakness after the focused ultrasound treatment. I would say that that's very unusual, if you would. Now, playing the bass guitar, to go back to what we talked about with the piano and the violin, you may find that quick, nimble activities become a little bit more difficult, whereas having control over those more slow, methodical movements actually tends to get much better because you don't have the interference of the tremor.
Thank you. Is the skull density measured before coming to Houston?
Yes, and very good question. So, because we do have a lot of patients that don't live close by, we've become just very adept at managing everything from online visits to doing a CT scan to evaluate the skull density ahead of time without the patient needing to ever come to the Houston area. And we've never had a problem finding a local facility that could do a head CT and do it with the proper protocol. And then they transmit the data electronically to us and we take a look at that. So the short answer is you don't have to come to Houston to have the CT scan done.
Great. Thank you. Is the basal ganglia a part of the thalamus?
Well, the thalamus is part of the basal ganglia. That's how I would restate it.
Okay, great. What is the difference between bradykinesia and tremor?
Yeah, so tremor is that unwanted or uncontrolled motion that people will get. And there's different kinds of tremor. It could be a tremor at rest, which is much more common with Parkinson's, a so-called pill rolling tremor. It could also be a tremor that's associated with activity or action. So some people with essential tremor, if they're just sitting in a chair, you can't even tell that they have it. But if they try to pick up a glass or a fork, then all of a sudden they start to shake. That's tremor. Bradykinesia is the absence of movement. Bradykinesia is it's very difficult to get your fingers or your hand or your arm or your leg to do what you want it to do. And it doesn't act in a coordinated fashion. It just doesn't respond to command the way that it normally would. So with tremor, there's extra unwanted, uncontrolled movement. And with bradykinesia, it's actually a paucity of movement where the brain is thinking, hey, I want to pick that up, but or I want to put that key into the lock, and you just can't get it in there.
Very good. Thank you. Okay. If tremors are due to, is it tardive dyskinesia, due to being on XYZ medicines in the past and now taking tetrabenazine to help with tremors and noticing some improvements, would it be worthwhile to investigate focused ultrasound?
Yeah,
I
so
am,
that's
go ahead.
go ahead.
Yeah, this individual's out of Chicago.
Yeah, so great question. And so here's the thing. I don't think that we have a lot of hard data to say definitively that focused ultrasound would be effective for this. However, I think that it would be. Okay. I think that it would successfully help to manage that tremor. Having said that, it would be, and I'd have to double check this, but it would almost certainly be an off-label use of the technology. And the problem with that then would lead to, hey, would it be covered by Medicare or one of the major carriers? And quite often they would say, it's not FDA approved for this specific indication. And so therefore, it's an off-label use. It needs to be done in an investigational protocol, and we're not going to pay for that. So that quite often is the practical uh, hurdle that we may run into.
Great, thank you. And final question, can you work through my doctor for my right hand tremor? And maybe the interpretation to that, Dr. Bonnen, is can one work through their primary care physician, neurologist, maybe explain a little bit of the background
Yeah.
on the appropriate referral?
Yeah, absolutely. So we'll work with patients and with their doctors however they wish. And that can be a whole variety of things. So we have patients that just come directly to us. They come to us without a referral or without having talked to their own doctors about it. And that's okay. We're happy to see them and do an assessment and tell them what we think and to communicate back to their doctor if that's what they would like. We have a lot of patients that are referred by neurologists. We have patients that are referred by primary care doctors. And of course, those patients that are referred by their primary care doctor are going to go follow up with their primary care doctor, and we're going to manage their tremor. With respect to the neurologist, we do get a large volume of referrals from neurologists, probably, the single largest source of referrals that we see. And it really depends a little bit on the neurologist. My experience is most neurologists want to see you back, and they would like to receive communications from us so they know when the patient goes back what's been done or what's transpired, since they last saw the patient. So we routinely do that. Sometimes when it comes to DBS, it gets a little bit more involved where neurologists are quite frankly different. There are some that want to see the patient back, but they don't want to have to manage the implant or the device or even the medications. There are other neurologists that do want to manage the implant and the medications. And so we work with your doctor and with you, the patient, to do what is going to, work best for everybody and putting the patient first. So whatever the patient wants us to do with respect to coordinating with their other physicians, that's what we're going to do. Most doctors want to see you back, and they also want to know from us what our assessment was and if you received any treatment, what that looked like, so that they're informed when you come back to see them. But that's pretty common, and so if you need a referral, we can typically work that out with your primary care to get the referral or with the neurologist.
Very good. Well, that concludes. So I want to thank you, Dr. Bonnen, for an excellent and very informative presentation. Equally is our audience. We had a great turnout today, and that's a concession of your respective time as well. So thank you to all of you. You had some great questions. Hopefully you learned a lot today. We'll keep this slide up here for a moment or two, but please take note. And if you do have additional questions, follow up and follow through.
Thank you.
Again. Appreciate it. Have a
Bye.
great evening.